So this slide asks the question, what's the big deal? And the problem is really simple. A student has to fail and fail regularly before someone says, hey, this kid needs help. And for years, many kids were failing because teachers used a one-size-fits-all model of teaching. So if you didn't learn it my way, then it was the highway. And if the student didn't learn that way the teacher taught, then it was obvious something must be wrong with the kid, of course. Now we understand more about individual learning styles, how to differentiate instruction to accommodate them, as well as students' readiness levels and interests. When I became an administrator, it was about the same time that IEP referrals had to contain a list of interventions that the teacher implemented to alleviate the situation. Typically, these interventions included moving the student's seat, calling the parents, and referring them to the guidance office or to the vice principal's office. Somebody missed the memo. I like the comment that if a child receives inadequate instruction, they are teaching disabled, not learning disabled. Part of the problem was that there was no research-based classroom interventions that a teacher could use, and I'll talk more about that later. Besides having to fail to get help, the IQ achievement discrepancy model did not consider the fact that maybe it was poor instruction that was causing the issue. Have you ever been in a classroom where you knew the teacher did not like certain kids and those kids typically struggled to pass? Of course, we all have witnessed that. I call that ego-induced learning disability. And it's the teacher's ego. The failure to learn is caused by the ego and the adult in the classroom. So you can see that it fails to consider that other factors could be part of the student's problem. So a severe discrepancy between test scores gives us no useful information about why that kid is struggling. So we know that the IQ achievement discrepancy model is when a student, say, has 100 IQ, so he should be functioning on grade level. So a fourth grader should be functioning at fourth grade, say, reading level. And if, in order to qualify to be learning disabled and then therefore to receive special ed help, you would have to be 2 years behind. So that fourth grader could have been a half year behind in the first grade, a year behind in the second grade, a year and a half behind in the third grade. You can see my point. So by the time the student gets to a fourth grade level, he's now 2 full years behind, but has been struggling the whole time he's been in school. And that is the big deal. IDA 2004 actually changed the wording. As you can see here, I've bold-faced, a local education agency shall not be required to take into consideration whether a child has a severe discrepancy. So you don't have to do that anymore. And that used to be the way it was done. And the second part says they can use a process that determines if the child responds to scientific research-based interventions. So it has now been put into the law. It's not mandated, and there are still school districts that use the IQ achievement discrepancy model because it's easier and their teachers don't have to do anything. With RTI, everyone has to be involved in the intervention, the charting of it, looking at the data, changing the intervention, etc., etc. So it's a lot more work than just giving a kid a couple of tests. All right. Okay, you can see here it says use a process that determines if he responds to scientific, and that's important, scientific research-based interventions. It can't be move the child's seat. All right. In this slide, I wanted to show that we have gone from a different model, problem solving, consultation, intervention, rather than wait to fail, refer, test, place. So that is a big idea. And you ask yourself, what would you rather see your child have happen to them? Wait to fail, or be addressed immediately when your child starts struggling? All right, this is a chart from Fisher and Fry's chapter, which you should react to in your double entry journal, those of you that are writing double entry journals. And this is the old paradigm where instruction and time were constant, and guess what changed? Guess what varied? Outcomes and learning, and that was okay in the old paradigm. You just weren't smart enough. But we know that's not true, that kids fall behind for many reasons. And it isn't always their fault. So we've changed this to a new paradigm where instruction and time vary, and we sometimes call time intensity, and the outcomes are constant. Now that's the ideal, and that makes sense. Okay, I've posted several definitions of response to intervention here. You may use any one you want in your vocabulary, in your own words. That little VIYOW, if you see that on a slide, that means there is vocabulary words on this slide. The vocabulary in your own words can be found in Session 2, Course Materials, Handouts. Also a reminder that anything that you have to read for an assignment can be found in two places. It's on the assignment page, and it's in Course Materials for the specific session. So just some information for you. Okay, Fisher and Fry say a way to vary instruction and time to create a constant level of learning. We just saw that. Bender and Shores, a process of implementing high-quality, scientifically validated instructional practices based on learner needs, monitoring student progress, and adjusting instruction based on student response. Cohen and Spencer, a systematic model for teaching and assessing student consisting of ongoing data collection, charting, and monitoring student performance. There's progress monitoring again. And here is Dr. Tom's, a process of using research-based intervention and increasing levels of intensity and frequency as an alternative to identifying students as learning disabled. So you may use reword, put those in your own words for vocabulary in your own words. All right, so what does RTI look like? It's known as a dual discrepancy model. So we'll talk a little bit about that. The first discrepancy is that naturally a student is found to be performing significantly below that of his or her peers. The second discrepancy is despite the implementation of one or more. Okay, so we're not mandated to just do one, and if that doesn't work, we can do more than one, and then chart progress. The student fails to close the gap between his or her peers. So this is a much more logical model, and it's been proven by research that it has kept kids out of special ed from being classified as learning disabled. All right. Most response to intervention models look like this. A three-tiered model with the first tier being classroom instruction for all students, the second tier being small group instruction for some students. This could be special ed, or it could be just pulling kids by a reading specialist, a math specialist, and using research-based interventions. Now, a lot of my students are confused, and they think that just pulling a group of kids in working with them in class is a tier 2 intervention, and that is not true. You have to chart progress. You have to use a research-based intervention that's different than the one they have been using, and then you have to chart their progress and compare it to where the average student should be. So to get to Tier 2, and here are the percentages that these are suggested percentages. 80 to 90% of all students should be receiving research-based instruction in the regular classroom. 5 to 10 get Tier 2, and Tier 3, which is special ed, would be individual research-based intensive interventions. So, and you can see the arrows that they go both ways, and we should keep that in mind, that students are not stuck in a tier for life. One expert on RTI likened it to a person who has high blood pressure. The first step in the process is screening, and that's part of the RTI process, universal screening. So every student that starts in kindergarten or pre-K, whatever the school district has, is screened to see where they are and what level they're at. Once it is determined that a person has high blood pressure, they may be treated with diuretics and then monitored. With frequent blood pressure checks, I'm always checking mine when I go to the supermarket or drugstore. Actually, I bought a blood pressure. As many of you know, I had cardiac arrest a couple of years ago. So I'm always checking my blood pressure, my pulse, my sugar. And I use healthvault.com, Microsoft HealthVault. So again, checking blood pressure, so the effectiveness of the evaluation can be evaluated. If the treatment plan doesn't work, then the doctor's not going to keep doing it. He's going to try another research base, because all drugs have been researched before they are put on the market. Like a beta blocker that could be recommended and again monitored. This is one of the complaints that I used to have when I was a high school administrator. Student diagnosed with ADHS or ADHD were given medication without careful and persistent evaluation of the results. So sometimes the student would be falling asleep in class, other times that had no effect, and the person was still hyperactive. So it's the progress monitoring using probes like blood pressure test, except we use academic assessments that are standardized and short. All right. This flow chart represents the 3 tiers of RTI. Primary prevention represents the general education setting. Students receive research-based instruction, and progress monitoring is used to identify students who are at risk for difficulty. So that's the first stage where you're identified. In Tier 2, so if they are determined to be at risk, then it's Tier 2, where they may get research-based tutoring, small group instruction, and then progress monitoring to see how it's working. And then if it's responsive, they go back to Tier 1, so they're not stuck in Tier 2. Unresponsive, they go to Tier 3, which is special education, progress monitoring to set IEP goals, progress monitoring to formulate individualized programs, and progress monitoring to assess responsiveness. Now, if that works, back to Tier 2. If not, then it's repeating the Tier 3 process until it works. And it may not work. All right. So what does a good school program look like? The essential components are, first, high-quality classroom instruction, which I've mentioned several times. Second, tiered instruction and intervention. Ongoing student assessment, universal screening, as I mentioned, progress monitoring with curriculum-based measurements and probes, and data-based decision-making, all of which should include family involvement. So that's what a good program looks like, and that's the end of this part 3, and I will be back with a little more information on progress monitoring and the use of curriculum-based measurements.